So we're going to demonstrate the casting of a transtibial residual limb, including all the markings and measurements and application of the liner today. First thing that I do is, Gary actually just finished up with his preparatory prosthesis. He's wearing 16 plies of socks in his current prosthesis. So because of that, I want to remeasure and make sure that the liner that's chosen is the appropriate size still. So we'll take a look at what he's using. And he has a size 30 liner and he measures a size 31 centimeters. So it is the correct size liner for him. So we turn the liner inside out, making sure that there's no disc shape at the bottom, reflect it completely all the way out, apply it to the distal end of the residual limb, and then roll it up in place. Therefore, there's no air pocket at all. When we're casting a patient, I like to have the patient relax slightly. You'll find if you fully extend the limb and they hold it there, their muscles contract and the limb takes a different shape. So by having them relax and slightly flex, it creates a nicer shape, and the gastroc muscle is not larger at that point. First thing I like to do is I reflect the top of the liner over just a little bit, and what that does is it holds the saran wrap that we apply to the outside of the liner. The only purpose of this saran wrap is to protect the liner from the casting material. So we take it, wrap it around. I like to have a nice, snug, firm wrap because it does hold the limb in kind of a snugger shape, especially if you have a patient that has a lot of redundant tissue distal. This wrap can actually support that tissue much the way it's going to be when the patient's wearing the prosthetic device. All right, so we've wrapped the saran wrap around. Now at this point you can choose to use a casting sock over top of it. And in this case I'm going to go directly over the liner because it's going to give me a more accurate impression of the patient's residual limb, and we're trying to get a nice small socket for him. So anything we put over the residual limb at this point is going to make the casting larger, and therefore the patient will wear more socks. First thing I like to do is find the patellar tendon and the joint space. By doing that, can you flex your knee a little more? Beautiful. The more the patient flexes their knee, the more it opens the joint space. So we like to mark the center of the joint space. I also like to palpate the patellar tendon, the medial and lateral borders of it, and mark the exact center of the patellar tendon. So at this point, we have that located. I'll now go up and mark the patella. This is not even inside the prosthetic device. Just gives me some reference as we're modifying the cast where the patella is actually located. At this point, I'm going to go down and locate the distal end of the tibia, which is here. We're going to put an X on that spot. The tibial tubercle, just below the joint space, we can locate that and put a line there. And as we know, the crest of the tibia is going to be between the distal end of the tibia and the tibial tubercle, so we can connect those two. Now at this point, the lateral compartment is a pressure tolerant area. It's a great area for pressure, so we want to find out how far to the center line we can apply that pressure. So I'll palpate where the lateral border of the tibia is and make a mark there. And we will follow that lateral border of the tibia all the way down, and then we'll follow it up. And this is the lateral tibial condyle. So I'm palpating that and coming around just like that. So we have the crest of the tibia, the lateral tibial condyle, and our border between the soft tissue and the lateral aspect of the tibia. At this point, I'll go around to the lateral side, find the fibular head, palpate the borders of that. You can either place an X on the center, or you can make a mark that goes around the fibular head. At this point, now we're going to come over to the medial aspect of the patient's residual limb. This is the medial tibial condyle, and what we're looking for is the inferior aspect of that. This is an absolutely fantastic vertical loading area in the prosthetic socket, so we want to locate the area that we can come in and put pressure. If we do it here, that would be on the bony structure, so we want to actually come underneath it. And this line indicates the shape that I'll be modifying and putting pressure there. And now we're going to palpate the medial aspect of the tibia over to its border where it becomes soft tissue, and bring that line down just like that. At this point, we're also going to find the proximal aspect of the femoral condyle. This is a nice soft tissue area where we can come in and put pressure and support the patient in the ML as they're ambulating, but we can't take a lot of material off here. So again, I want to find that border, which is here. We're not going to take a lot of pressure here, but we will be able to take some good pressure proximal to that. At this point, one last area would be on the lateral aspect over here, and that's the distal aspect of the fibula. He's got some wonderful soft tissue coverage. Physicians used his gastroc muscle, wrapped it right around. It's very difficult to palpate the distal aspect of his fibula. If I really push in with my thumb, I can find it right there. This is not a bony landmark that I'm going to really need to worry about in my modification, but I'm just making a mark there because on other patients you may need to. So relax your knee again, beautiful. And that's going to be the attitude which cast him, and we are ready to wrap that up now. I'm using C-form cast tape. We can use flexible plaster. You can use rigid plaster. There are some clinicians that actually use fiberglass. So there's a variety of different casting materials that you can use. I've found that this casting tape is a nice blend between getting a great circumferential wrap along with being able to highlight some of the bony prominences. I use an anchor wrap about midway up the residual limb, and then I come from the posterior to the anterior, which is much the way that I wrap an ACE wrap. If your patient has some redundant tissue, it will help to draw that up and again create a shape that's going to be similar to when he's in the prosthetic device. You can see the rest of my wraps are kind of a figure of 8. There are no circumferential wraps that just go around. If you do those, then you are much more likely to get roping in your cast and it won't turn out as smooth. My first wrap, I like to make sure that I get great coverage distally. The entire residual limb is covered. We kind of mold this in at this point. And now I'm going to move quickly to my second wrap, and then create the shapes that I'm looking in the pressure tolerant areas as it's setting up. Again, I'll anchor the end of that wrap in place, do one figure of 8 at the distal end, and then work my way proximal. At this point, because there's not, and relax your leg again, beautiful. It's very much the tendency of the patient. As I'm moving the patient around and wiggling his limb, sometimes they'll firm up and try to hold it in place. So we want to just remind them to relax. As you move up the residual limb, there's less soft tissue. Roping does not become as much of an issue, so you can go kind of circumferentially around. You can see I'm creating the trim lines of my prosthetic device with my cast. I like to do at least 3 layers proximal. That seems to be enough that will hold the shape when it's removed at the end of the casting procedure. Any less than that, if there's only 1 or 2, then it becomes too weak, and sometimes they'll curl in when you take it off the patient. At this point, I've got a great circumferential wrap, but I haven't really isolated any of the pressure tolerant areas. So as it starts to get warm, which it has not yet, but I will put pressure using the palm of my hand in the anterior compartment here. I'll also really try to define the medial aspect where we're getting that vertical loading over here. Some techniques, some clinicians will actually put their thumbs in the cast to designate the joint space. Bend your knee a little bit. Great, there's the joint space. I've got 2 thumbs. I've found that if you focus on this, it tends to, and especially if you reach around and put pressure in the popliteal region, which is also pretty common, what that does is it moves your ML out. For me, one of the most critical measurements on this cast is going to be a stable ML. I can modify in the soft tissue, so I do not tend to really focus a lot on either the patellar tendon marks, and certainly don't focus on pressing the popliteal region and creating a flat shape back there. At the most, sometimes I'll move my hand proximal and distal to kind of flatten the area just a little bit, but I tend to focus on the bony structure in the anterior aspect of the cast, putting really good pressure in the anterior compartment and creating a shape over here on the medial aspect too. Now this cast is actually very warm now. I am continuing to mold it like this, creating the shape that I'm looking for, but it is almost completely set off now.